Welcome back, everyone. We left the best for last, which is the tricuspid valve, and probably one of the areas that's growing incredibly quickly. Welcome back to some of our panelists. We have Anita, Nicolas, Edwin Ho, Susheel, and Neil. We're going to get straight into it. And again, stay with the same format, see where we are currently, maybe look at a live case with some new technologies, and then look into the future. So Edwin, we'll start with you.
Okay, great. Thanks for the introduction there. So yeah, I'll get things started for this section on tricuspid valve just by looking at sort of where things are at before we sort of move forward in terms of what looks like the future. Those are my disclosures. So, what's reality in 2025 is that, we have pretty established technologies, a lot more standardized procedures, better imaging compared to where we were, 3-5 years ago. So the reality is we can actually get a lot of people's TR treated well. So what I wanted to do in this particular section was talk about what the landscape just looks like very briefly, talk about what the approved devices are and very briefly what the evidence is, and then talk a little bit about the decision-making and treatment selection algorithms, which I think is the sort of more interesting contemporary part of all of this now. So, of course, there's no surprise that there's both surgical and transcatheter options for tricuspid intervention. And for the most part, we're talking about TR, of course. But since our focus here is on transcatheter, let's just quickly look at what's actually approved. So this is the US focus section. So we have TriClip and Evoke that's commercially approved by FDA. Health Canada, similar approvals. And then in Europe, they're quite lucky. There's more options available from a commercial point of view for treating TR. What's investigational? I think we'll hear more about this in a little bit, so I'm not going to go into this in much detail, but you can see there's still a very large number of devices that are active in the investigational space, and they target different mechanisms and different treatment pathways for TR, whether it's edge-to-edge, annuloplasty, a replacement, both heterotopic and orthotopic. In terms of where we're at right now, so if we think first about TIR, so we have TriClip approved, as I mentioned. What's exciting is now we have this brand new, fresh 2-year data from the US Triluminate pivotal study, whereas at the 1-year mark, we were really seeing benefits and differences for patients from the point of view of their symptoms. Now we're actually starting to see differences in the other clinical outcomes. So what was really interesting here, even though there was some degree of crossover and potentially sort of diluting out a beneficial effect, with intention to treat, we actually still see that heart failure hospitalizations were actually improved at the 2-year mark. And it looks like those curves start to diverge right after that sort of 1-year point, which I think also tells us that, a lot of these patients, it may take some time for us to see differences between treatment or not treatment. And so it's always important for us to be checking in on the newest results all the time. In terms of what else we know from the Triluminate study, so, we talk about the anatomy and what's appropriate for TIR. There was a single-arm registry cohort that looked at complex anatomy. And what's reassuring here is that we do see that despite complex anatomy, the reduction in TR is still substantial, with about 80% of people achieving moderate or less TR, and they still get some degree of quality of life improvement. In terms of moving on to replacement with Evoke, so this was the pivotal 1-year data, where again, we're really seeing that there's dramatic differences in terms of patient symptoms and how they're doing. We didn't see any hard outcome differences yet, but just like with TriClip, I guess we'll see what comes out in the next couple of years as the longer term follow-up is available. What we do see that's a little bit different between replacement and repair is the degree of TR reduction, which is maybe not that surprising. So unlike with TIR, where we're seeing about sort of 80% moderate or less, in this situation here, it's greater than 99% moderate or less, 95% mild or less TR. Again, all of us who are being involved with these technologies, there's no surprise when it comes to replacement. Unfortunately, nothing in life is free. So, of course, that does come at some degree of trade-off or consideration, at least. Not to say that this is necessarily a dangerous procedure, but certainly from the risk point of view, it does look like there's more risks than when we're looking at edge-to-edge repair. So as you can see on this table here, predominantly the things that we really care about and pay close attention to has to do with bleeding and also conduction abnormalities requiring a new pacemaker. So the numbers here look definitely higher, but of course at the trade-off of better efficacy in terms of reduction of TR. Quickly looking at some of the not yet approved device categories. So in terms of other tier, Pascal was undergoing the CLASP TR2 study, which actually closed enrollment. So hopefully we'll have data from that relatively soon. This is from the non-randomized CLASP TR study, which again, similar to TriClip, shows that, when you look out to 1 year, about kind of that 80% mark have moderate or less TR. And then again, from a symptom point of view, we do see significant benefits. And this is observational, but it does look like there was some difference in heart failure hospitalization for this particular subset of patients. So hopefully we see that pan out as well in the randomized study. Looking at other categories of devices, so very quickly, this was from the Cardioband TR-EFS study in the United States. So this is a direct annuloplasty device, and we do see a successful annular reduction. So there's definitely device efficacy. From a TR severity reduction, we see that it's a little bit variable. It seems to sort of remodel in the positive direction over the course of the first year. And this probably has a lot to do with the underlying anatomy. We do see, of course, a lot of patients with very advanced stage TR, where it ends up being kind of a little bit of a mixed etiology and not necessarily pure annular dilation. What's reassuring from the European data from a device like this is that, we talk a lot about leaflet complexity, and I'll go into that in a little bit shortly. But of course, devices that are leaflet agnostic are fortunately also potentially agnostic to the underlying leaflet anatomy. And this study just looked at the type of TR reduction you get, regardless of the complexity of the underlying leaflets, whether it's, 4 or 5 leaflets versus 2 or 3 leaflets, which makes a lot of sense, but it's nice to have some data that confirms this suspicion. And then lastly, thinking about valves that don't go into the native tricuspid annulus. So this is just data coming from a tric valve. Smaller numbers, of course, but we are seeing that, patients again have symptom improvement. It looks like they are able to tolerate less diuretics. From a safety point of view, it seems pretty reasonable. There is still some signal in terms of bleeding, as well as potential thrombosis formation, of course, because we are dealing with prosthetic leaflets here. So, when I used to give talks like this a few years ago, I used to focus a lot on this type of, treatment decision-making algorithm that was really heavily based on anatomy and trying to match, device with the exact anatomic mechanism. But as I mentioned, it's a little more complicated than this because a lot of patients come to us with really a mixed etiology, and there's a lot of other clinical factors that come to play. So it's not as simple as just saying, okay, well, this one directly goes here, this one directly goes here. So I just wanted to present some sort of thoughts to sort of spark some discussion about how we try to approach this. If we sort of think about TR as a larger scale, of course, we think about surgery, but there's not a class 1 indication for isolated tricuspid valve surgery. And then we have our transcatheter options, which is repair and replacement. And in some centers, of course, access to clinical studies. So how do we really end up choosing between those two? So do you do sort of TIR first, or do you think about TTVR first? Here, I'm going to sort of just mention that maybe it's reasonable to think about TIR first. Of course, it's hard to argue against that safety profile, as I mentioned. And now we have the 2-year data from Trilunate, which actually suggests that the improvement to the patients may be beyond just for symptoms. Of course, we know that the actual grade of TR reduction is less than in technology such as replacement. And there's sort of these open questions about what happens if there's treatment failure down the line. Do you have options for retreatment and potential lifetime management? At the end of the day, maybe just like mitral, we start with evaluating, is this optimal or suboptimal for TIR? There's lots of publications out there about factors that influence success rates. This is the GLIDE score that came out of a multi-center evaluation. It doesn't bring necessarily any sort of new factors compared to what we've seen in a lot of other observational data, but I think it does bring all of those factors together, especially for newer centers or newer sites, if they're really thinking about how do I approach this to understand, is this going to be a complex TIR or non-complex TIR? So no surprise, some of those leaflet factors in terms of gaps, where the jet is, how your image quality is, chordal structures, all of that is going to come into play in terms of the likelihood of really good TR reduction. At the end of the day, more simplistically, I always just think about it as leaflets, leaflets, leaflets. And views like these transgastric views really kind of tell that story. So your coaptation lines, like the red line, your leaflet gaps, which are those yellow arrows, it really helps dictate the overall anatomic complexity. And I think that that's really ends up being the major factors that push you towards TIR or, not TIR. And of course, in these types of views, you can also see things like leaflet mobility, chordae, how much tethering there is. So I'll just propose two very quick sort of algorithms that, different centers approach tricuspid intervention in different ways. This would be an example of sort of like a tier first treatment algorithm. So if we were thinking about somebody for transcatheter intervention, the first question becomes, is this anatomy okay for tier? And everything sort of pushes towards that tier perspective, unless there's really something that pushes you away from it, like the anatomy, like huge gaps that you clearly are not going to be able to clip. And then only in that situation do we run down the sort of replacement algorithm about anticoagulation tolerance, are the risks in particular with respect to bleeding and pacemaker risk appropriate? And then depending on whether or not a site has access to clinical studies or not, we really talk about EVOQUE when we're talking about FDA-approved devices. On the flip side, some centers may think about things more as a TTVR first treatment algorithm, really sort of aiming from the point of view of trying to maximize TR reduction and hopefully potentially giving that, maybe valve-in-valve lifetime treatment option. And then the questions become a little bit different because then the initial questions about the patient have more to do with anticoagulation, TTVR risks before we even start thinking about, okay, is this, anatomically appropriate for TR or not? So two different approaches, and I think different centers will take these approaches differently. And I think as new data comes out, of course, this is going to be changing. So probably in a year's time, we'll be thinking about and discussing this in a very different way, depending on what, for example, the 2-year TRISCEND data looks like. So in summary, hopefully I've been able to just quickly show that there's a large landscape of tricuspid intervention options. Not a lot that's FDA approved, but we have at least one valve, one repair option. Of course, Europe has more devices available. And at the end of the day, hopefully I've been able to show that the data really pushes in different directions. So it's most important to really approach this from an individualized patient level perspective to evaluate the risks and benefits. And then for the most part, the question is always, is it reasonable to consider TTR first? Probably, based on the data that we have so far. But certainly there's clearly a role for TTVR as well. Thank you.
Edwin, Azeem has to take a call about a patient, so he left us for a couple of minutes. Susheel, you have a lot of experience, also research experience with the tricuspid tier and then TTVR. What is your take on this? Are we already there to do a randomized comparison between tier and TTVR, or should we follow more the algorithm that Edwin has presented?
Yeah, I think it's tough. I don't think we're there for that randomized sort of trial. I think because the challenge is the anatomies are really quite variable, and patients that are appropriate for one may not be appropriate for another, and we get to this sort of decision making of which patients are we going to enroll in a trial, and then you're going to get a really sort of small population that's eligible for both. I approach it in many ways how Edwin does. Spoke about it. In general, we generally try to avoid replacement in the tricuspid surgically, and I try to do a repair first strategy. I think where I struggle is, I think we've learned a lot over the last 5 years about who's a good candidate for TIR. There are the patients where I feel very comfortable, but there's ones that I'm completely opposed to TIR, where I'm saying they got to be TTVR. But that middle zone is not so small where you could sort of consider TIR, but maybe I'll get a good result, but then you have TIR regrets because you get in there and 4 hours later you're like, why am I still here? Or the imaging, where you thought the imaging was good and you're in there and you can't see, and then you have an ICE catheter and you're struggling, or you have a lead which is behaving sort of unexpectedly. There's that large middle zone, and that's where I struggle. I feel very comfortable on the edges, but the middle is unfortunately not as small as I would like it to be. And that's where it's going to be evidence and knowledge about who's an appropriate candidate, what are we learning, and a level of comfort and experience that's going to drive to that. But I don't feel comfortable we're at a randomized trial stage for repair versus replacement, because it's just such different populations that are in each study.
Yeah. So that said, we had two beautiful live cases of TTVR, one with an EVOQUE and one with Luke's valve on day one of TIO this year. All within the hour, super controlled, hemodynamically perfectly stable, and excellent results. So I think TTVR really seems to be a little bit more mature than TMVR. And maybe, Neil, you can also demonstrate that in the recorded case that you prepared for us. Neil is muted. Wow. Seems that we have a technical issue.
Well, Neil's getting his voice back. I think the one thing I would say that you mentioned, I think TTVR is definitely getting more mature. I think the safety profile is improving, but the question of durability and in this population of a bioprosthetic valve in the tricuspid, as we move to somewhat younger patients, and again, this is a sick population, I understand. I think that's one of my concerns, but I agree with you completely. The safety profile as we get dedicated TTVR devices and experience will continue to improve. Neil, are you able to?
Anita, what is your view on TTVR failure? Is this something? I mean, will it be easy to do a revalving procedure in your opinion?
More than likely, because I think we're going to have a lot less of the complications that we see with everything else that we do. There's no LVOT, obstruction is going to be low. Pacemakers may be an issue depending on whether or not the patient got a pacemaker initially. I think that might be a potential issue. Anticoagulation after, it seems like most of these patients are going to require chronic or lifelong anticoagulation. So I think from a valve perspective, that's not going to change very much. But to Susheel's point, I think understanding durability is going to be an important issue. And obviously, we don't want to have to do these procedures quite quickly after the initial intervention. I would add one comment about tricuspid tear, and I think what's going to really be important, and I think our practice is very similar to what Edwin showed, but regardless of what strategy you choose, the goal is going to be try to reduce that tricuspid regurgitation as much as possible. And we learned that on the mitral side for mitral tear. So we can't accept an inadequate result no matter how we're doing this, but particularly I think with tear, some of those cases can be challenging, and we really are going to have to push. I think accepting moderate, which is what we did in the trial, is probably not adequate, and we really have to get that TR reduction as low as we possibly can. I think Neil made a comment earlier in the mitral session, removing clips is something that would be an interesting thing to be able to do. There are ways to do it, but dedicated devices to do it may make a strategy of TIR first easier if you can remove these devices and then put a TTVR after the fact.
I agree with you. I think this clip removing technology, that is so compelling, and that will be a game changer once we are able to do that, because then you can come up with a strategy. Okay, let's do a repair first, and for whatever reason, if we fail, we can remove it and then proceed with a TTVR. I like that concept a lot, and this is probably the near future. And I assume that Susheel is going to address that later on. Edwin, maybe another question for you from an interventional imaging point of view. Is it different, tricuspid tear versus a TTVR, or are you using the same principles, the same techniques?
Basic techniques are relatively similar. Generally the replacement devices, I find they're a little bit less imaging intensive because you don't usually have to see the leaflets to the same degree as TIR. I think 3D ICE has really changed how TIR is done, especially in the United States where it's used quite a bit. But definitely if I were to pick one or the other from an ease point of view, I would pick replacement.
Okay. Neil, it seems that you're back.
I hope I'm back. Can you hear me?
Yes, we can.
Okay, fantastic. I don't know what happened there. So I'm going to show some new technology. Hopefully the technology works. The slides are not advancing. There's no advancing button on my screen just for the tech support. There's no arrows to advance the slides. Well, we'll just keep going. So we have a toolbox for tricuspid, just like we discussed for mitral. It's interesting that the pace of development in tricuspid has gone much more briskly because, as it turns out, the tricuspid valve is much more forgiving than the mitral valve. You can leave TR behind. RVOT obstruction is largely unheard of. PVL is better tolerated. So for all these reasons, we've actually been able to advance things in tricuspid faster in some respects than mitral. And I'm going to be mainly focusing on valve replacement. Next slide. So what have we learned? So we have a bunch of TTVRs. The Evoke was the first to get FDA and CE approval, but there are a number of other very interesting devices which are following close behind, which are either in single-arm studies or soon to be in pivotal trials. And so we're going to focus on one of these novel technologies, which is the TRICARE's Topaz valve. Next slide. So the Topaz valve is a two-stent design. It's very soft, flexible device. It has an outer frame which conforms the anatomy, an inner frame which houses the 28 millimeter porcine pericardial valve. So the interesting aspect of this device is it's not so focused on leaflet capture. This is a self-expanding valve. The first iteration was 45 millimeter, and the second one can go up to 57 millimeter tricuspid annulus. It just has a single row of very small hooks or tines which help with the anchoring. And it has this hourglass shape. So really the implant simply has to be centered on the annulus, and we'll focus on that. Next slide. So here's a zoomed up shot. You can see a single row of anchors. This is on the medium-sized Topaz. And then the second iteration, which is the large valve, has two rows of tines. Next slide. So this is a transfemoral percutaneous 29 French, very easily to place sheath, which has a couple of features. It has a primary curve, and then it has a secondary curve, not for getting off the septum, but to adjust the depth. So I don't know if you could just click the next slide. And you go forward. Yes. So I'm happy to share with you the first in human large Topaz implant that we did last year. And as I said, this valve can treat patients up to 57 millimeter tricuspid annulus. So this is a 62-year-old man who had torrential TR, not a good TR candidate, AFib, some mild rheumatic involvement of the mitral valve, and the heart team decision was for TTVR because of large coaptation gap, very tethered leaflets, and multiple scallops. And based on CT analysis, the perimeter drive diameter was 49 millimeters. Next. So here's the echo. You can see big coaptation gap in the middle, very tethered leaflets. Next. So this is one of the few tricuspid procedures which is mainly fluoro-based. So we start by doing an RV angiogram. And if you just focus on that very solid set of markers here, that simply needs to be placed slightly ventricular of the tricuspid annulus. You have a wire in the right coronary as another marker of the annular plane. And then simply the valve has to be placed very central in the annulus and perpendicular to the annulus. And then you simply start slowly unsheathing the valve under fast pacing. Usually pace around 150 beats per minute. The patient remains quite stable. Next slide. So here's the very slow expansion. You have to make sure as you open the ventricular side that you don't get caught on any subvalvular apparatus, in particular the moderator band. But this is very controllable, patient stable throughout. And if you notice that the outflow of the valve is compressed in any way, just simply pull it back slightly and it will free itself. So you can see here the hourglass shape, which centers itself on the annulus. And if you click again, you'll see the same thing on echo. So it is a hybrid fluoro echo guided procedure, but really the implant itself, once you have the delivery system across the tricuspid annulus, takes less than 10 minutes. And so here you see the echo equivalent of what you saw on fluoroscopy. So very flexible. Initially, when you implant the valve, there are some PVCs because the larger valve does have, I would say, a pretty generous ventricular footprint, but these things tend to settle down. And we have seen reproducibly elimination of TR. We haven't seen any afflow mismatch because it is a very soft frame. And we've been pleased with the results so far. Next slide. So I personally believe that if you can implant a valve, a transfemoral, that's great. Left femoral also helps to deal with septal hugging trajectory, but the jugular approach is also very complementary for many TTVRs. And in this case, we had a patient, 74-year-old woman with massive TR, a typical patient you might consider a TTVR, but she had a very significant septal hugging trajectory with a big IVC offset. And so we discussed various options and in the end landed on doing a TOPAZ via the jugular approach. Next slide. So it's really quite similar to other jugular approaches. You pre-close, put the 29 French sheath in, it went very easily. And then it's the same thing you saw from the femoral, but from above. Here, there is no septal hugging whatsoever. We're right in the center because of the way the SVC entered the RA. And then it's simply fast pacing, controlled deployment, unsheath. And next slide. Next slide. Yeah, so here's the fast pacing. The valve is deployed. I want to emphasize that while you're doing that fast pacing, the patient's really stable. And if you don't like your depth or your position, you can actually still adjust it before the valve's fully deployed. Once the atrial side is deployed, obviously it's done. But with the ventricular part flared, there is an opportunity to adjust before you go all the way. Next slide. And final result was excellent. Patient did really quite well. So I think it's all about providing options and trying to minimize screen failures. Probably not all of the valves we use will have a jugular option, but certainly Evoke has been done many times via jugular approach now. Some of the other newer valves, such as Lux and Monarch, are only jugular. But I think having multiple access options just improves options for patients. Next slide. So I think we've seen amazing innovation in this space, which allows more options for our patients. I do believe that TTVR will become a dominant therapy, but it needs to be made safer. And we're all looking to see the 2-year follow-up of TRISCEND 2. And I think the ongoing trials, along with novel device development, will really push the field forward. And I'll thank you for your attention.
Thank you, Neil. I know we can always count on you to show us kind of, the most topical, most cutting edge procedures because you really are doing all of them. And I think, Lux really highlights how quickly and rapidly this field's moving. And we're going to have Susheel kind of finish it off by showing us, besides Lux, what else is coming down the line. Susheel.
Great. Can you guys hear me okay? Okay, so these are my disclosures. I think Edwin did a nice job of sort of setting the current landscape and really talked about a tier first algorithm and talked about Evoke a little bit and some of the challenges. I wanted to sort of focus on TTVR and talk about next generation systems. Right now, the approved devices with Evoke, it's really a mitral platform that's been used in the tricuspid, and even with Intrepid, it's being iterated, but it's a mitral platform used in the tricuspid, and that's worked, and it's gotten us far and gotten great results. But it's important to understand that TTVR is not the same as TMVR. With TMVR, the delivery systems anchor on the septum at a puncture point that we dictate, and that allows us to get coaxial and much more control. In all of transcatheter valve interventions, coaxiality is key. And that's one of the challenges in TTVR, because there is no fixed anchor point and the IVC trajectories are very different. There isn't a fixed anchor point that leads to challenges in getting coaxiality, which can be difficult with some of these TMVR systems. And Neil talked about this last patient where he went jugular, and it's interesting, jugular access in terms of valve delivery may be easier, although ergonomically, we're not used to it as interventional cardiologists because you don't have this offset. And this is what's unpredictable. And you see this example here where the IVC comes in, and here's the tricuspid annulus with that circle. And you see that it's really quite offset. And so some of these delivery systems, the Evoke has to be quite flexible, and the delivery catheter is quite flexible and flexible in multiple planes. And you see on the left, this is sort of ideal. There's no offset. You do a single plane of flexion, you have enough height, and you come straight down. Whereas in this example here, you see that you have a 90-degree secondary bend and then flexing down. And that poses challenges for delivery systems. And there's, and the delivery mechanisms also vary. As you saw in the Topaz valve, you deliver from the ventricle first and unsheath. Whereas with the Intrepid, you unsheath in the atria and you push down into the ventricle. And so those two mechanisms dictate, do you need a lot of ventricular depth if you're going, atrium to ventricle, or do you need a lot of atrial height so you have enough room to come back? And those are important to understand from a delivery system perspective, because if you need a lot of ventricular depth and you don't have it, you can cause RV injury. If you don't have atrial height, you may not be able to pull up enough and you get stuck and the valve deploys low. And these are important to understand when we're choosing devices and delivery catheters are created. And then one of the big things with TTVR that we've talked about is RV function. We in general, RV function goes down when you replace the tricuspid valve, and that's true surgically or transcatheter. Now, that's not the same as saying cardiac output goes down, because forward flow in these studies still goes up, but RV function goes down. Now, why does RV function go down? Is it because you've gotten rid of TR and there's more after, and that's just reflective of non-realistic RV function at baseline? Is there increased afterload with getting rid of the TR? Is it because you're putting a big device at the base of the RV that's impacting RV contraction? And it's important to keep in mind that RV contraction is very different from the mitral, where on the right side there is a significant component of longitudinal, and you see in this example that how the RV function goes down when you replace the tricuspid valve. The other big limitations with TTVR are conduction disturbances, and that's important. In these initial studies, the rates with Evoke, which is the one device that we have been anywhere from the teens to 25% of pacing, requiring pacing. In addition, when you looked at the TRISCEND study, nearly 40% of patients had a pre-existing pacer. So it's not only the post-management conduction disturbances, but the pre-management of patients with existing leads. And that's something that is a big challenge with TTVR. We can jail these leads, and that's what we did in TRISCEND to a large extent, but that can pose problems. And there was about a 6% incidence of lead failure post-Evoke. And that's something that we have to keep in mind. And also, if there's endocarditis, how do you get those leads out? So lead management, both pre and post, is a big challenge with TTVR, and we have to continue to understand that as we develop new technologies and move this forward. In terms of conduction disturbances post, we also need to understand how long do you observe. We generally don't discharge on day 1 or 2. We usually keep patients about 72 hours to watch. And if they do need, and we send everyone out with an MCOT. If they do need pacing, how do you do it? Our preferred approach is coronary sinus, although we've done leadless post. We really want to avoid transvalvular pacing leads, and maybe we need better technologies to manage pacing needs post-TTVR. Another big challenge with TTVR is leaflet thrombosis, and we talked about this. Leaflet durability, as Anita mentioned earlier, is a big challenge and a big question with TTVR. In all these trials, all patients are anticoagulated. And in our experience, every time we stop anticoagulation, you get this thrombosis of the leaflets. And so now it resolves with starting warfarin on this patient. And at this point, I've taken the approach that we're going to need lifelong anticoagulation post-TTVR. And most of the patients we do Eliquis, although some have failed that and required warfarin. And we may need studies to what kind of anticoagulation is required as well. Will there be valve designs that will reduce the need? Because that's important, especially on the tricuspid side in a low flow state where 95% of patients are in AFib. Thrombosis is going to be an issue. It may not just be leaflet. If we have low flow states with a lot of metal that we're putting on the right side of the heart, that can lead to thrombus formation in the atria and other areas as well. So this is something that is a big challenge, and we have to understand, and maybe leaflet designs and stent frame designs may modify this risk. But whatever it modifies it's always going to be a concern and a challenge. And durability. And here I have a blank slide because that's the reality. Because we know from the surgical literature we try to avoid bioprosthetics on the right side because they don't last as long. Now, but there are patients where it does and others where it doesn't, and we don't understand it. How leaflet designs will impact durability is something that we have to learn. And then lifetime management and revalving strategies we discussed earlier is going to be an important issue. So we need dedicated TTVR valves. Tricuspid annulus is very different. It's larger, more elliptical, less fibrous tissue. We have to think of the anchoring mechanism differently in these patients. And we have to the right ventricle is different from the left. As I said earlier, movement of the base contributes a lot to the cardiac output. So big, bulky devices that immobilize the base may drop cardiac output further than others. And we need to try to minimize the RV footprint because, in some designs, and now TRICARES is different and TOPAZ is different, but in some designs, that large RV footprint may reduce RV stroke volume. And we need to optimize the hemodynamics from the right side. We need large EOAs. We need to minimize gradients as much as we can, 3 to 4 millimeters of mercury. And the valve design needs to reduce the risk of leaflet thrombosis in all these patients who are in a low flow state. And we need to think about how we reduce risk of conduction disturbance, but also how we manage it if it occurs, and then also how we manage patients with pre-existing leads when we look at these TTVR designs. So there's a bunch of newer TTVR platforms. We saw the Topaz valve. Here's a handful of others, and there are others as well. But these are, most of these valves are different. They're all started with the premise of designing for the tricuspid, except cardiac valve, which started in the mitral. But the rest are dedicated tricuspid devices, and that's important because they're trying to address the differences between the tricuspid and the mitral. I'm just in a couple of minutes just going to show you a few that are a little bit different concepts. This is the V-dyne. It's a unique shape. It tries to match the tricuspid annular shape. It's not circular, as you can see. It has a very low profile. And perhaps the most innovative concept is a unique side delivery system. The valve is not unsheathed from one end to another. It's a side delivery, and I'll show that in a second. It's mostly a fluoroscopic driven procedure. The valve anchors in the RVOT and in the posterior shelf. And they have some unique design features. A pop-out valve that you can open if you have afterload mismatch that creates some degree of TR. But also this pop-out valve is a circle in a location where you can put a new pacing lead if you need to without going through the leaflets. And this valve is fully positionable and retrievable. And all valves are delivered through a 29 French delivery system. There's 5 implant sizes. And as I said, it's retrievable. And in our first case that we did last month, we ended up having to retrieve the first valve because it was too large a size, and we had to then put in the smaller size valve, and it worked well. Start with there's an RV gram, and as you see here, you sort of engage the RVOT with this tab, slowly unsheath the valve, and then you push it down posteriorly. And that's one of the biggest challenges is, can you push in a coaxial direction? Can you get the valve down? And you see here, the valve here is pushed down posteriorly, anchors in the RV. It requires echo, but you're not looking at leaflet capture. And so a lot of it is floral landmarks that you're looking at. And you see the echo result in this patient here. The Lux system is another unique tricuspid. It sort of has less radial force anchoring at the annulus to try and minimize conduction disturbances. It is delivered through a transjugular approach. It's a bovine pericardial valve. It's a retrievable delivery system, and the anchoring mechanisms are unique. As I said, it has some tabs that capture some of the leaflets, but it's not a lot of radial force to minimize conduction issues. But there's a septal anchor that goes into the septum to hold the valve in place. And there's multiple sizes and has some of the largest sizes available. As I said, it's an IJ delivery system. The sheath is advanced in, it's unsheathed, and you see here the septal anchor up here, that's that little triangle. And so that there's an anchor that's fired into the septum that holds the valve in place, in addition to several tabs on the leaflets as well. Again, as I said, very little radial force to, again, minimize conduction issues. See the results here. Another Laplace delivery system, and you start seeing themes here. Again, it's not a circular valve. It's trying to match the shape of the tricuspid. It's got a flexible outer cuff, and again, it's similar to the V-dyne. It has an anterior flap that anchors in the LVOT and these posterior engagers. It tries to minimize the footprint in the RV as well, and it tries to, because of this asymmetric design, it tries to minimize the pressure on the AV node. This is also a transjugular system, a 26 French. And again, with the low profile, you have less potential RV high PAP exclusions. This again has done a few limited EFS cases. It's a 26 French delivery system. It's a bovine pericardial trileaflet valve, low radial force. And again, similar to V-dyne, they have a provision to put a pacer without having to go through the leaflets. And you're starting to see some similar concepts. The last is a very unique design. It's the Trisol valve. This is one of the last ones I'm going to highlight. It is a bileaflet tissue valve, which is the first that I've seen of this kind. It's a very large valve, and there's some theoretical benefits to it. There's some potential benefits to patients with RV dysfunction because it has because of its large leaflets, has gradual leaflet closing, which reduces pressure on the RV. And there's potentially an increase in cardiac output to this large valve opening and increased cardiac output. Again, they have large valves. They have a 65 millimeter valve coming soon. It's again a transjugular, although they're working on a transfemoral system. Again, they've minimized the force at the annulus. As you can see, it's a waist in at the annulus and it anchors on with these tabs on the leaflets. And again, try to reduce the risk of a pacemaker. This is their initial experience that was presented, 17 patients, able to deliver the valve. There was some paravalvular leak in some of these patients, but what you saw here is that the impact on the RV function was not as dramatic as we'd seen. Now, this is early experience. They showed some improvement in RV function, but we'll have to see how that pans out in a larger series. But I think that's one of the important components. So, there's a lot of novel TTVR devices, and so we've got these dedicated TTVR systems that have been developed. They're all looking to address the limitations that we talked about earlier, but there's still going to be limitations, and we just have to get a lot more data, and we'll see which one of these pan out in the end. So I'll stop there. Thank you very much.
Great, Susheel. Really exciting how this field is rapidly growing and so much happening. Neil, we have time for just a couple of quick questions and comments. You've implanted multiple of these different devices. I mean, how generalizable is this? I mean, I'm sure there's a lot of people in our audience seeing this and going, is this something I'm going to be able to learn how to do? You've mentioned in your Topaz case how we're moving to maybe more fluoro-based. Maybe just give us some context about how generalizable you think these technologies will be.
Generalizable, then TTVR is for sure generalizable. These procedures generally take 30 minutes or maximum, an hour, whereas Susheel mentioned a TTR can sometimes take several hours to get the result that you like. So I think it's very teachable, reproducible. The TRISCEND 2 trial enrolled very quickly because it's a reproducible procedure in multiple hands.
Okay. Susheel, again, multiple technologies. Are there enough patients for this? I mean, is tricuspid a big enough field that we need so many technologies?
No, I mean, it is a big field. I mean, we still have to understand who to treat and when to treat. So I think there's room for several technologies. There's not room for all of these technologies, right? The reality is we're going to have to get some understanding and data and see which ones of these pan out. And I think the ones that are going to win are, at Neil's point, ease of use. If things require a ton of imaging and a ton of things to do, it's going to be hard. Safety profile is going to be important. Managing conduction disturbance is going to be important. So I think we'll see a couple of these sort of rise to the top. I expect in 5 years, 10 years, the technology we're using now are not what we're going to be using. But I do also expect tremendous growth in repair, and our ability to do repair on the tricuspid will be improved with ICE, AI, robotics. In 5 to 10 years, I think we're going to look at repair very differently than we do now as well.
Thank you. Thanks to all of you. Thanks, Anita, Nicolas, Edwin, Susheel, and Neil. It's been an incredible morning for us here in the US. Exciting structural sessions and aortic, mitral, tricuspid. It was great ending with tricuspid because it was just filled with innovation and about what's about to come. It's amazing that there, 6 devices currently in clinical study right now around the world. So it's a really exciting field. Thank you all for joining. I think we're going to follow this there's a very exciting symposium on mitral regurgitation. So please continue to join TIO 2025. Thank you everyone for your participation.